Hello everybody, so my name is Rose. I'm a professor at King's College London and I am here to talk about cardiovascular complications resulting from weaning and tying it back to some of the evidence, particularly in terms of our weaning trials. So in terms of my disclosures, during my PhD I did a randomised controlled trial of SmartCare. For that, Dragon Medical Australia gave me a box of mints. Since that time, Dragon Medical UK flew me from Canada and took me out to dinner to give a talk, and I've also received some speaking fees from Dragon Medical Singapore and was on a DSMB for Hamilton Medical. So starting off, just reviewing cardiac function during positive pressure and potential risk factors, particularly in patients undergoing cardiac surgery. So again, very much a refresher. We've heard a lot about this already over the last day and a bit, and we'll continue to do so. So what we know in terms of the physiology, cardiac function is affected by changes in intrathoracic pressure and lung volume. We know there is a decrease on the right side of the heart of venous return. There is a variable effect in terms of pulmonary resistance, so increasing lung volume and vascular compression can cause increased pulmonary vascular resistance. However, conversely, the non-ventilated area recruitment can result in a decrease in hypoxic vasoconstriction and a decrease in pulmonary vascular resistance, overall resulting in a slight reduction in ventricular workload, oxygen demand and output, with a lot of caveats in that, as we've seen in some of the presentations. So what happens in the left side of the heart? We see that there is a reduction with that left-right ventricular output, resulting in a reduction in left ventricular filling. Increasing intrathoracic pressure also reduces left ventricular end diastolic pressure, with decreased transmural pressure and decreased oxygen consumption. And also, positive pressure will reduce work of breathing, hopefully, and giving sedation, as we do pragmatically to facilitate ventilation, will decrease sympathetic tone, which also decreases pulmonary vascular resistance and decreases heart rate. So just a little bit of a review over there. Overall, reducing cardiac load and oxygen demand. So what happens when we switch to weaning? So obviously when we are weaning, we are going to reduce the amount of positive pressure support that the patient is receiving. And in some cases, such as spontaneous breathing trial, we may significantly reduce that positive pressure support and switch our patient back to normal breathing. So during a weaning procedure or a spontaneous breathing trial, we see a decrease in intrathoracic pressure with a resultant increase in pre and afterload. There is increased work of breathing with weaning, as we know, and we'll get increasing sympathetic tone, not only because we've now reduced or turned off the sedation, but also our patients may be stressed and very anxious with the weaning procedure. So overall, an increase in oxygen consumption. And some of the consequences associated with that may be acute ventricular dilatation, myocardial ischemia, mitral regurg, heart failure, and weaning-induced pulmonary edema, which I'll come back to later on in my talk. And as I said, I just briefly touch on some of the risk factors that are known in terms of weaning failure in cardiac surgery patients. And so in this review, they've identified 6 studies with nearly 35,000 patients in total, which for us in intensive care is a large patient number. But you can see there in terms of pre-operative risk factors, only a couple of these reviews have identified left ventricular ejection fraction of less than 30% as being a pre-operative risk factor for cardiac failure. So cardiac function and the impact of weaning strategies. What happens when we wean patients with what we do? So first of all, just to review what we might consider to use when we're weaning. So we have the opportunity to use spontaneous breathing trials, which I'll come back to on my next slide. We also have the opportunity to use either progressive or a static use of pressure support ventilation. So we either progressively reduce or we switch to a set level of pressure support. We have tools such as weaning protocols that can help us with that. And we have a variety of automated closed-loop or proportional modes, such as SmartCare, which is an automated version of a weaning protocol of pressure support. We have adaptive support ventilation. We have IntelliVent. We have proportional pressure support. We have proportional assist ventilation. We have NAVA. And we also have the opportunity to potentially consider early extubation of a patient straight onto non-invasive ventilation. And this may be an option, particularly for COPD patients, that we might want to consider. So obviously, we're going from an immediate switch in ventilation support. So as I said, I'll come back to spontaneous breathing trials. What are they? They are a focused assessment of the patient's capacity to breathe without support. That's what they're used for. And they are the major diagnostic test for extubation readiness. And so when you look at all the criteria, whether they be within the context of trials or whether they be in the context of clinical protocols, absence of cardiac compromise, so no change in instability in terms of hemodynamics or neurarrhythmias, is very commonly listed as an indicator for spontaneous breathing trial success. However, not all SBTs have the same cardiac implications. As I said, if you do an SBT that uses pressure support, it may not be the same in terms of the cardiac complications as an SBT that uses a T-piece. And so with a T-piece, when you remove the patient completely off the ventilator, you're generating a bigger reduction in intrathoracic pressure, and potentially this has more utility in diagnosing weaning-induced cardiac failure, which again I'll return to. But given weaning is my thing, I thought I wanted to highlight some of the variability in our practice that may then also influence what we're seeing when we're seeing cardiac-induced weaning failure. So this is a large international survey led by Karen Burns from Canada, asking centres in different regions, so across Canada, India, UK, Europe, Australia, New Zealand and the US, how they weaned their patients. And you can see here that the most predominant common method of weaning across these continents was pressure support with PEEP. And you can see there's a lot of variability in terms of the use of other methods of spontaneous breathing trial, whether that being using CPAP without pressure support, using T-piece, but also with PEEP or without PEEP. She followed on the survey with a large observational cohort, recruiting 142 ICUs, again across these regions. So just shy of 2,000 patients. And again, very interested in weaning and discontinuation practices. And you can see there again, so surveys, they tell us what people think they do, what they think we want to hear. Obviously, observational cohorts tell us what's happening in practice. So again, you can see a lot of variability in terms of the frequency of screening to do a spontaneous breathing trial. So infrequent use of screening in Australia, New Zealand and the UK, more commonly done in US, India and Canada. And in terms of, again, SBT conduct, again, more commonly done with pressure support and PEEP in countries like the US, Australia, New Zealand, UK, Canada, and more commonly done with a T-piece in India and Europe. So again, when we're thinking about are we detecting weaning failure that is of cardiac origin, the way we attempt our spontaneous breathing trials and the way we wean our patients may influence our ability to detect this. So I said I'd come back to weaning-induced pulmonary edema, which has got the acronym of WIPE or WIPO, depending on whether you're a UK or US spelling, which I think is slightly amusing. So it's due to a change in pulmonary hydrostatic pressure, and its incidence of around 20 to 40%. And it commonly occurs very early in a spontaneous breathing trial. So if you're popping your patient onto a T-piece, those patients that immediately going, this is not going to be a happening thing. And it may be responsible for up to 60% of failure in patients that do fail weaning. There are some known risk factors, so patients with COPD, patients with existing structural cardiopathy, low left ventricular ejection fraction, and obesity. However, its incidence seems to be infrequently associated with actual myocardial ischemia, and fluid removal may increase the chance of subsequent spontaneous breathing trial success. As with spontaneous breathing trials, you don't do them once and walk away, you repeat them at regular intervals. So how are we going to detect whether a patient has got weaning-induced pulmonary edema? So generally, clinical findings are not sensitive or specific enough to help us with this. And we have a range of tools now available to help us detect this by doing this and monitoring our patients at the beginning of a spontaneous breathing trial and then towards the end. So we can look at occlusion pressure, but obviously we know that use of pulmonary artery catheters has decreased substantially around the world with increased risk. We can use and look at increase in extravascular lung water, increased BNP, increased concentrations of plasma protein or hemoglobin, and negative passive leg raise or B lines and ultrasound. And as you can see, there was illustrated in this paper by Lou, you can see that there are changes before and after the conduct of a spontaneous breathing trial. Just highlighting you this other study that was published that was looking at the use of lung ultrasound to diagnose weaning-induced pulmonary edema. And you can see here this was a T-piece trial, spontaneous breathing trial of 1 hour. And at the end of the trial, there was increased B lines on the 4 anterior points, which the authors suggested was the best in terms of accuracy for diagnosis, and asked for further studies to be conducted. Looking at B-type natriuretic peptides, so just as a reminder, these are produced by cardiac ventricular myocytes in response to volume or pressure overload. And there are 2 types, so BNP or the N-terminal pro-BNP. And in this study here that was published very recently, just this year, they looked at 323 post-surgical patients that were ventilated for greater than 24 hours and identified 45 patients that failed weaning after a 2-hour T-piece spontaneous breathing trial. And they identified that in terms of prediction of weaning failure, that the change from baseline to the end of the SBT in the NT-proBNP was the best predictor and better predictor of weaning failure than either minute ventilation or the rapid shallow breathing indexes, which is one of the commonly used predictors of weaning failure. Moving on to echoes, so this systematic review published a couple of years ago was looking at the use of echo parameters to measure left ventricular ejection fraction and left ventricular diastolic function, or measured on commencement of spontaneous breathing trial. And so you can see there by the forest plots, so the closest towards me looking at left ventricular ejection fraction, they found no association with the 11 studies that looked at this. Whereas with the measures that looked at left ventricular end diastolic pressure, they did find an association with weaning failure. So right ventricular dysfunction and relationship to weaning failure in non-ARDS patients. So there has been some indication that this may be predictive in patients with ARDS. And this is a secondary analysis that comes out of Frederick's group and Marcus Schultz's group here in the Netherlands, where they did a secondary analysis of their PREVENT trial, which was low versus intermediate tidal volume, and RELAX, which was restricted versus liberal PEEP. And they found no association with these parameters looking at right ventricular dysfunction on either successful extubation or mortality. So overall, there are now a couple of algorithms. So the algorithm closest to me on the stage that was published nearly 10 years ago by Martin Dresden colleagues. So really identified, thinking about, do you have a suspicion that this patient might be at risk of cardiac-induced weaning failure? And so you can perform the spontaneous breathing trial. So in this algorithm, they said perform the spontaneous breathing trial, and if they fail, then do a series of investigations. Whereas on the far side, the more recently published algorithm, thinking about potentially doing these series of investigations. So as I said, thinking about doing an echo, doing ultrasound, measuring BNP and so on and so forth at the start of the spontaneous breathing trial, because when they fail, then you've got a good indication of whether that is a cardiac induced weaning failure. So within the remit of my talk and with the time scale, I'm not going to obviously into treatment of weaning failure of cardiac origin, but obviously there are potential for fluid removal strategies and a variety of different medication titrations with vasodilators, nitrates, beta blockers, calcium channel blockers, etc. So moving on to the final section of my talk, so cardiovascular complications and adverse events that are reported in weaning studies. So this is the BREATHE study. So I was fortunate to be a co-investigator on the BREATHE study, which was a study of early extubation to non-invasive ventilation in patients that failed a spontaneous breathing trial. So patients that we would normally just pop back on the ventilator and maybe give them another day and try again. So in this protocol, that clinicians, as long as they were convinced that there wasn't an absolute contraindication, if they were in the early extubation to NIV arm, that was what occurred, and they were put on an IPAP and EPAP equivalent to the pressure support and PEEP that they were on previously. And in the other arm, there was progressive reduction of pressure support and an SBT, which was viewed as common practice in the UK. And you can see there that there was a difference in the numbers of patients that required reintubation, though this wasn't statistically significant. But when you look at the adverse event reporting for this trial, there's limited adverse event reporting for cardiac parameters. But in terms of dysrhythmias, and as I said, one of the criteria for failing a spontaneous breathing trial is often a new onset arrhythmia, there was no difference between the two groups. In fact, there was less dysrhythmia within the non-invasive weaning group. So moving on to some of the recent trials that have looked at pressure support versus T-piece. So as I said earlier, potentially T-piece is more diagnostic of cardiac induced weaning failure. So this is the Subaru trial that randomized over 1,000 patients meeting standard type weaning criteria. So patients that we would all consider to wean. And they compared either a 30-minute SBT using pressure support of 8 centimeters of water and no PEEP versus a 2-hour T-piece. And in this trial, you can see that 93% of the pressure support group were extubated after the first spontaneous breathing trial, so they passed their first trial, and only 84% of the T-piece were. So arguably that drop, that difference between the two groups might be where we're seeing that fewer people passed their spontaneous breathing trial because it may have been of cardiac origin. But we really don't know in the data that we have. And again, when you go to the table of adverse events and look at those relating to cardiac events, there is very little cardiac arrest, thankfully, and very little bradycardia or development of hemodynamic shock, and definitely no difference between the two groups. Moving to the more recently published trial by Thea in New England. So here, this trial was looking at patients at high risk of extubation failure, recruiting just shy of 1,000 patients. So high risk of extubation failure, so our older patients with known underlying cardiac or respiratory disease. They again used a spontaneous breathing trial of 8 centimeters of water and no PEEP, and versus a T-piece trial and only 1 hour. And again, there was not that much difference in terms of the numbers that passed, and obviously not statistically significant, that passed the spontaneous breathing trial. And again, looking at the table of adverse events, those that reported hemodynamic instability between the two groups was virtually the same, and again, relatively low numbers. So this is after the first spontaneous breathing trial, looking at around 10% of the patients. And again, going through the adverse events, very low incidence of cardiogenic pulmonary edema or cardiac arrest. And in terms of reason for intubation, again, very, very low numbers in terms of requiring this. Just pointing out too, the WeanSafe, you can't talk about weaning without the WeanSafe study. And again, so this was a large epidemiological study, it wasn't a trial, but again, it's one of our largest epidemiological cohorts focused on weaning in recent times. And so they identified 65% of this cohort that weaned just shy of 4,500 that had one separation attempt, and a variety of different parameters there. But again, within this cohort, because we know that we've got patients in our weaning profile that will wean very easily and potentially don't even need a spontaneous breathing trial. So you've got 10% of the cohort that are in that difficult to wean branding, and 10% that are in that more prolonged weaning. And so, interestingly, in this table, when they were looking at variables associated with weaning failure, the only variable associated with decreased risk of weaning failure was chronic cardiac failure as an admission reason. Very interesting, I think. So in conclusion, what I've pointed out in my presentation is that we know that shifting from positive to negative pressure induces changes in preload and afterload, which causes an increase in myocardial work and oxygen demand. We know that there is cardiac dysfunction due to the stress that weaning contributes, and this is determining its contribution has challenges, but we have a variety of tools now in terms of ultrasound, echo, measuring BMP, passive leg rise, and extravascular lung water that can help us detect this when we're suspicious that it may occur, and our treatment depends on the underlying pathophysiology. TP spontaneous breathing trials may be a better way to identify cardiac intolerance to weaning, but overall, internationally, they are used less frequently than pressure support ventilation. And that our large weaning trials frequently do not report differences in cardiac events comparing these two weaning strategies, but perhaps we're not using the right tools to measure cardiac compromise in these trials. And with that, I thank you for your attention.
Thank you very much for this very comprehensive talk. We have time just for one question in the audience. If not, I have one. How do you explain the paradox between the last slide where having chronic cardiac failure is
when
protected?
I was preparing the talk and I looked at it, I was like, what? Have I got that the wrong way? So I'm not quite sure, right? I think there's further work to be done to investigate why that is. Potentially, clinically, clinicians have been more cautious, and so therefore that might be the reason why. But I think it's very hard to pick out at this point in time.
And maybe the reason for intubation being heart failure may be different from pneumonia or ARDS with more complex patients.
Exactly.
Thanks again.
Thank you.